My name is Olivia Shaw, student number 2203735. I'm going to be demonstrating ILS. Firstly, I want to be considering my Dr. CAB-CDE approach to the situation. I'm going to be checking for any dangers in the environment, such as wires, liquids, bags and other people. Once I've determined that the area is safe, I will approach the patient and assess the patient triangle by looking for their efforts of breathing, their colour and their position. Also at this time I can be looking around for any evidence of catastrophic hemorrhage by looking for obvious staining on the patient's clothing or obvious pools of blood. Once I've determined there is no catastrophic hemorrhage, I can apply the AVPU scale to the situation by talking to the patient, introducing myself and asking if they can hear me. If the patient does not appear alert or respond to my voice, I would perform a pain test which would involve squeezing the trapezius to see if the patient reacts. Soon after this, I will perform a head tilt chin lift, ensuring I feel at the top of the spine for any potential C-spine injuries. Head tilt chin lift is performed by placing 2 fingers on the chin and the palm of my other hand on the patient's forehead, and I'll be looking into the patient's mouth to check for any blockages to the airway. If there were to be any blockages, I would use a suction to extract these. If I felt there was a risk of the patient's tongue obstructing the epiglottis, I could use an airway adjunct such as an OPA, which is demonstrated in my video. OPAs are beneficial in maintaining patient airway if there was a risk of the patient airway collapsing. I will next assess for breathing and circulation. I will assess for breathing by placing one hand on the chest to feel for the chest rising and falling. I can also visually check for this by looking down the patient's chest, and I'll be placing one ear above the mouth to listen for breath sounds. To check circulation, I will place 2 fingers over the carotid artery to feel for a pulse for up to 10 seconds. After assessing patient triangle, the AVPU scale and utilising the Dr. CAB-C scale, I would determine that the patient is unresponsive. Once I've determined that the patient is unresponsive, I would inform my crewmate that the patient is in cardiac arrest and delegate which area of ILS I would like my crewmate to perform. At this point, we would need to expose the patient to access their chest for compressions and defibrillation. This falls under the exposure category of the Dr. CAB-CDE approach, meaning although necessary, it's still important to ensure that the patient is dignified, especially in a public setting. As seen on the video, I instruct my colleague to begin chest compressions at a rate of 30 compressions to 2 breaths using a bag valve mask. Whilst my colleague does compressions, my focus is on using the bag valve mask to perform the 2 breaths required, and also early defibrillation by applying the defibrillator pads to the patient's chest. Early defibrillation is important because we can identify the rhythm in which the patient's heart is performing so that we know if they are in rhythm that is able to receive defibrillation. AF, atrial defibrillation, and pulseless VT, ventricular tachycardia, are the 2 shockable rhythms. Sinus rhythm and supraventricular tachycardia are non-shockable. I recognise that my patient is in AF and therefore able to receive shocks via the defibrillator. I set the defibrillator to the appropriate joules, which to begin with is 120. These joules increase with each shock required. I am now ready to charge the defibrillator and administer the first shock to the patient. I inform my colleague that the machine is charging and will inform her once more when I am going to deliver the shock. It is important that I tell my colleague to remove hands from the patient and step away so they are not at risk of receiving the shock themselves. It is also important that I remove the oxygen at least 1 metre away from the patient. Other risks during shock administration apply to the patient, meaning I need to check the 6 Ps, which are position of pads, pacemaker, pendants, piercings, perspiration. Once me and my colleague have moved away and the risks to the patient have been removed, I will administer the shock as seen in the video. Immediately after administering the first shock, I instruct my colleague to recommence chest compressions as it is vital to reduce the amount of time spent off the chest. Reducing time spent off the chest is vital to patient survival because you are essentially performing the job that the heart usually does to keep the patient alive. Another important aspect is effective CPR. Although it is vital to stay on the chest where possible, effective CPR means recognition of your crewmate becoming exhausted and knowing when to ask them if they would like you to take over compressions. Among these, keeping track of CPR cycles is crucial. This allows everyone on scene to know when a rhythm check is required. It allows other practitioners to see how long we have been performing ILS and also allows others to recognise you potentially becoming exhausted and not performing effective compressions. 1 cycle is equivalent to 5 rounds of 30 chest compressions to 2 breaths. After the first shock, I allow my colleague to continue in this first cycle of ILS whilst I upgrade the airway using the airway ladder approach. In the video, this is demonstrated by tilting the patient's head to one side to remove the OPA and placing the patient's head back into position so that I can insert an eye gel. I can be seen to demonstrate using a laryngoscope, which allows me to open the patient airway and shine a light to ensure I'm inserting in the correct way. I lubricate the eye gel to reduce trauma to patient mouth and insert. Once this has been inserted, I can be seen to connect the airway circuit. This is done by attaching the tube to the eye gel, then attaching the filter to this, then attaching the ETCO2. Once I've upgraded the airway, my colleague has finished the first cycle of ILS and it is time for a rhythm check. We determine that the patient is still in AF, so we perform a second shock, upping the joules to 150. I instruct my colleague that after this second shock we will switch joules and I will demonstrate a full cycle of chest compressions at a rate of 30 compressions to 2 breaths via the BVM. The 2 breaths will be performed by my colleague.